Connie and Kate. Thank you. I'm really pleased to introduce our next two speakers. And our first is Dr. Kathleen Obray, and she is with the River Road Internal Medicine Clinic here at Dixie Regional Hospital. So I'm going to turn the time over to her, and she will introduce the second speaker. Thank you.
Okay, thanks. It's a pleasure to be here. My name is Kathleen Obray. I'm an internist. And I will be introducing Helle Brande, who is a physician assistant, in just a minute. She is actually going to give the bulk of this talk. I wanted to just let you know that I want you to ask questions throughout this. It's going to be pretty informal. But before we get started, and before I tell you a little bit more about myself and why I am semi-qualified to give this talk, I wanted to get a little bit more information about you because I understand this is a caregiver conference. And I want to find out first how many of you are currently taking care of somebody or have taken care of somebody who has a current diagnosis of dementia? Okay, so you're in the throes of it now. And how many of you are concerned that maybe a loved one has or may have dementia? Okay, and maybe are needing further help with getting a diagnosis. Okay, so like I said, I am an internist. That means I'm an adult primary care physician. I work part-time. A few years ago, about 2.5 years ago, I decided to actually work even more part-time and decided to devote more of my time to learning, figuring out ways that we can, from a population health standpoint, figure out how to take better care of our burgeoning senior population here in southern Utah, and really figuring out how we can take care of our patients with cognitive problems. Unfortunately, there are a lot of people at Intermountain Healthcare interested in doing this, and so we have a whole team of very dedicated people interested in doing so, and we've been able to get funding from our foundation to do something that's a little bit novel. It's actually not that novel, it's just that most people can't get funding to do it, and that's to have a memory care team. So we have a team embedded within our primary care medical home at River Road Internal Medicine, which is how we got Helle Brande here, and a social worker who's in the middle there, Jill Stevens. Raise your hand, Jill. And we also have a clinical pharmacist, one day, and a medical assistant. And this team is able to see patients in our clinic. Unfortunately, we can't open our services up to other people. We're hoping to expand the model and really make this standard of care throughout our community. So I'm just throwing that out there because I know there's going to be questions and there's frustrations about getting people diagnosed, but I also know how important it is to get this diagnosis so that you can take better care of your loved ones. I also have learned in the last 2.5 years and before then how important it is that I, as a primary care physician, may help you recognize that your loved one has a problem and help you answer your questions and connect you to the resources that you need in the community. And that it's not a one-time, you have dementia or your loved one has dementia, but that I have to take that into account every time you come in or your loved one comes into the office. And that every time your loved one goes to the hospital, that people need to recognize that you or your loved one has dementia. And that the needs are going to change over time. And that really it's not me as the primary care physician that's doing the work, it's people like Helle, it's people like Jill, and it's people like Luann Lundquist at Memory Matters and her team, and all the people at home healthcare that are really helping you and that will help you for the next 10 years out in the community. So without further ado, I'd like to introduce Helle. And Helle is really quite remarkable. We're quite lucky to have her in our community. She's not just helping people in our clinic, but she's really doing a lot by giving talks like this and other places. She, I don't even know all the things she's done, but what I do know is that she was, early in her career, she owned a children's bookstore. Then she was a physical therapist, which is an invaluable skill to have when you work with older people. And then for the last 11 years, she has been a physician assistant working at Banner Alzheimer's Institute in Phoenix, which is a top-notch, world-class facility taking care of people with all forms of dementia. And there she has learned amazing skills. I have said this many times, but I really have yet to meet anyone, including physicians, including neurologists, who have better skills than she does at taking care of people with dementia and really communicating to families what it means to understand people who have dementia and the behaviors they have and how to help them lead meaningful lives. So here is Helle. She's going to help you understand these things better.
Okay. Good morning, everybody. It's really good to be here, and can everybody hear me okay? Okay. So I just want to say a couple of things on the research subject. I've been lucky enough for the last 14 years to have worked with some of the top researchers in the field. And it's important to realize that Alzheimer's disease was actually identified over 100 years ago, and then just sat on the shelf until the late 70s. When the research field picked up, and it's only been since the late 70s that we've recognized Alzheimer's disease as a separate entity, that we've moved away from a model of senile dementia, of recognizing that this is not a normal part of aging. We've moved in the time that I've worked in the field from a position of hopelessness to a position of there might be hope. And there's a good, strong feeling in the field right now that we can get to a point of managing this as chronic disease, okay? We've recognized that the plaque that he talked about is laid down 10 to 20 years before the disease manifests. That allows us to look at prevention studies for the first time in our lives. That's a huge stepping point in the field, because a lot of what we found is the science of all of the studies we've done for Alzheimer's disease is still good, but maybe we've been addressing it too late, so that some of the treatments that we hoped would be useful didn't prove to be so. But maybe if we can back up and look at things, and I'm so glad to hear of the Pointer study, look at lifestyle modification and some of the huge prevention studies that are going on. We're at a point where we can actually measure and see plaque and tau on FDG structural studies. So that's allowed us to shorten up our study length and have smaller subjects so we can get through research faster. If you say your medicine is going to reduce plaque, I want to be able to measure that. If it's not, you're done. So it's a really exciting point in the Alzheimer's or the dementia field. So let's go on. So the first thing when you get a diagnosis or you are suspecting, the question, even after you've had a talk about Alzheimer's and dementia, is always, it's just dementia, right? Not Alzheimer's disease. And as was pointed out to you, dementia refers to the symptoms. It means that somebody is having memory problems and they've progressed to a point that it's affecting their function. So we use a lot of this umbrella, right, dementia, but you can also think about it like with cancer. If you went to the doctor and you were told you would have cancer, you wouldn't settle for just that as your diagnosis. You would need to know what kind of cancer, because that might determine what your treatment is, what your prognosis is, what your opportunities for participation in research are. So, as was pointed out, Alzheimer's is the predominant cause of dementia, and then you have a whole host of others. I won't belabor those because she did a great job. So, when it is Alzheimer's disease, she mentioned that each dementia has, I kind of call it its own story, its own picture. And it is, what is that presenting symptom, that first noticed symptom that often begins to clue us as physicians and healthcare providers as to what kind of dementia there might be. So when you come to the doctor and you're talking about the symptoms you've seen, what we want to hear is that insidious snake-like onset. You aren't sure about it when you're going through it. It's only when things have gotten more noticeable and you look back that you say, aha, you know, it was maybe 2, it could have even been 3 years ago. We noticed little bits and pieces of forgetfulness, and then that seemed to progress. We noticed it became more predominant, And then it started to affect the ability to do tasks. Mom wasn't remembering birthdays. She wasn't remembering ingredients. The food didn't taste as good. We noticed the house wasn't being kept as well. Those would be a typical story, but the first symptom is that forgetfulness and a vague date. There's not a specific onset. And the other thing you would have noticed is the brain, as she went through the different lobes and functions, the brain is not just memory. The brain is about language and judgment and reasoning, problem solving. So all of those, because this is a neurodegenerative disease and it spreads through the brain, all of those get affected. So you might also have noticed word finding difficulty. They seem to struggle with coming up with a word or lose the train of thought more. So in the context of getting a diagnosis, and the diagnosis means that you, A, take your memory complaint to the doctor, and you have cognitive screening that suggests, yeah, there are some problems. You have a physical exam, because we're always looking at what are those causes, those factors that may be contributing to memory problems. So we're ruling out a whole host of other problems. Imaging studies to look in the brain, and just to clarify, we don't normally do a PET scan. That's an expensive procedure, and the only indication Medicare will use that for is if we can't tell whether it's frontotemporal dementia or Alzheimer's disease. So we typically do a CAT scan or an MRI. So when we look at cognitive tests that say, yeah, this suggests there's a problem, we don't see anything else in the brain like a tumor or evidence of stroke that could have caused the problems. We hear a story, we get a picture of slow, gradual changes over time, then we can talk about the Alzheimer's disease, okay? So when you hear a diagnosis, sometimes it's just that shock value. Even though you suspect, that moment that you get it confirmed is still hard. So it's important to recognize you're only human. You need time to process the disease, whether you're the person who is experiencing the dementia symptoms or whether you're the family care provider and you're hearing the diagnosis. It's a whole system that gets affected. Make sure that you ask questions. What does this mean? Or maybe you're the kind who needs to go home and process and then come back for another appointment to talk about it more. But take that time to process. Understand that your emotions can be all over the place. There can be grief. There can be real sorrow with hearing the diagnosis because we all have the image of end-stage Alzheimer's disease, and this is horrible, and how is it going to be, and worries about the future set in real quick. So you can have anxiety. There can be denial. It's hard to hear something. And the important thing is that people in very early stages are also really good at covering up the problems they're having. So they talk around a word, they use humor to kind of deflect. They talk more. So if you're coming up to something they're not as comfortable with, they talk around it. They go off on tangents. So it's easy to reinforce that maybe there isn't a problem. And in the early stages, they're still fairly independent, but are going to need more help. So there's lots of ways that denial kind of gets reinforced. People can be at different points in how they're handling their emotional reactions within the family. Nobody's right or wrong here. It's the coming together slowly and sharing the talk, the feelings, and getting educated as we're going to talk about it. And then as you're comfortable, it's important to share the diagnosis, okay, with those people who you feel would want and benefit from knowing, because that's where you're going to start assembling the team we're going to talk about. After the diagnosis, it's going to be really important to identify what are the key concerns we need to address, depending on what stage the person is in. And this can include medications, treatment, and how do we manage medications, because The potential for making mistakes with allowing somebody who has more advancing Alzheimer's disease is significant. So when do we need to step in and take that over? Finances, they can be forgetting to pay bills, they can reverse numbers, they can overpay, underpay, they can give away money that they don't have. I've had families where the person with dementia, before it was diagnosed, had actually given away, spent it, whatever, in a whole host of ways. $1 million. $1 million. Okay? My dad gave away $5,000 signing up for sweepstakes. So there are lots of ways that the management of money can become impacted. So it's important that we're on top of that and we begin to provide oversight and realize when it's time to take over. Meals. If I can't remember to cook, who's going to make the meals for me? They often revert to snack foods, so if they're living alone or they're being left alone, there's a lot more sweets in the house and less healthful eating. And we can see concerns for weight loss. General safety, driving, we're going to just table that on the side. That's a whole separate conference, and wherever all of the people are. We want to schedule a day-long conference for driving and aging. Weapons in the home. If somebody becomes more confused, more paranoid, suspicious, angry, doesn't recognize who you are, thinks you're an intruder, I'm going to worry about that gun being easily accessible, okay? Being left alone. If my judgment and reasoning is not intact such that I can recognize an emergency situation and even more, respond to it. So if I haven't used the phone in 6 months, and when you ask me how would you handle an emergency and you can't recall 911 as an emergency number, that is a person who cannot be left alone, okay? Same as a child, right? It's the judgment and the reasoning has changed such that they can't be left alone, at least from moderate stage forward and sometimes even in early stages when the judgment is more impacted. Are there mood or behavioral symptoms? Depression, anxiety, irritability, suspiciousness, paranoia, wandering. There's a whole host of behaviors that may need to be addressed. Sleep patterns. Are they able to fall asleep, stay asleep? Are they getting up early? Are they up and down all night? Are they sleeping excessively during the day? These are all types of situations you may encounter. Your own caregiver-related concerns. Where is your mood? Where are your spirits? Where's your resilience, your flexibility, your ability to get through the day, to cope? Finding activities. This is an important one. As the person with dementia loses more of the ability to plan and appreciate wants or needs, they sit more. And this is where you may interpret it as laziness. That all of a sudden they're not doing the household tasks. It's just he just wants to sit in TV, watch TV all day long. Doesn't want to go anywhere, just sits. Well, they've lost that ability to come up with their own initiative, to plan an activity. So it means that we need to be the facilitators, or as I tell caregivers a lot, it's the nudge. You're the nudges, okay? You are the keepers of time, the keepers of purpose, the keepers of what will bring meaning and pleasure to them, because that's how you address your other concern, right? How many of you, if you stepped out of the caregiver role and just imagined yourself having Alzheimer's disease, or just thought about Alzheimer's disease, would say, no way, just take me out and shoot me. Let me out in pasture. It's a horrible disease. There's nothing good about it. And yet I will tell you that people will continue to express gratitude for being alive, to express gratitude for having family. The quality of life as they've lived it is changing, but the quality of life moving forward is affected by how we impact it, okay? What we bring to the mix. And then the other, after the diagnosis, is planning for the future, the what ifs, okay? This is going to take time, this is going to take money. How much money do we have? How are we going to provide for all of this?
there any questions at this juncture? Anybody want to ask anything? Okay. How many of you who are caring for a loved one with dementia how many of you, did your loved one have that diagnosis made by a primary care provider in the office? And was it an overall okay experience? For anybody, was it not such a good experience? Did it take a long time, or?
I haven't had a diagnosis for my mom yet.
Okay.
And when I talked to her doctor about it, he says, well, she's 88, that's normal aging.
Okay.
So he's been reluctant to even pursue it.
So you feel like there's definitely something more going on?
Definitely.
Okay. And so you're sort of in this limbo and you're not feeling like you're getting
Right.
the resources and what you need. Okay. Okay, well, we're going to talk. So this next little part is really what kind of team do you need when your loved one has dementia, and who are the people that can help you, and how should that go? So there probably are a number of people. There may just be the primary care provider. And you may need to choose you may already have a doctor, you may need to choose a new doctor. And hopefully there is some sort of team that will be able to help you. And that you'll have good relationships built on mutual respect and good communication. So, what makes a good healthcare provider? You want somebody who's communicative, understanding, supportive, reassuring. You want to be able to be comfortable with them, and somebody who's responsive and open-minded. I know oftentimes, I'll have patients who come in and want to try 20 different supplements they've read about, and I know a lot of providers will just say, no, not going to work. And, oftentimes I will feel no in my head, but I know that, we all, when we know that there's not a cure and we hear things, we want to believe that there's something will help, and some of these things may help or may not hurt, and I'm not going to immediately dismiss what somebody says, and we can work on things together, and we can see, and I don't know everything, and there may be new things that can help, and we can work on it and decide together. So I think it is important that we're all open-minded as we approach difficult problems. So, of course, I'm a primary care physician. Is this okay? Can you hear me at this range? Okay. So, I am the quarterback. No, the primary care physician, hopefully in most situations, will be the quarterback, but especially for patients who have Alzheimer's dementia. We are capable of making that diagnosis and helping patients with Alzheimer's. Now, but not every primary care physician is going to be as comfortable. Some of us are better at some things than other things. I'm not as good at certain conditions. It's a broad field, being a generalist and an internist, and we gravitate towards some things more than others. So some primary care physicians are going to send off a patient with dementia to a specialist sooner, and that's fine. There are some basic things that we would hope our primary care physicians will start doing better. And it was mentioned earlier by Kate that this annual wellness visit is becoming standard of care. And one thing that is recommended, or is more than recommended, is that we do a cognitive screening for patients 65 and older. And that's called a mini-cog, and it's a 3-item recall. You have to remember 3 words, and then you draw a clock, make it say 10 past 11, and then remember the 3 words. How many of you have done that? So, and that is really just catching people with moderate to severe dementia. It's not catching people with mild cognitive impairment or even mild dementia. We are just trying to get people who have moderate to severe dementia and making sure we're at least getting those people diagnosed and helping them. But again, so part of most important, or at least at the very beginning, is having a primary care physician. Also on your team may be a physician assistant or a nurse practitioner, and that may be in place of the primary care physician. Or in addition, of course, neurologists play a big role in taking care of patients with dementia. But again, not every patient with dementia needs a neurologist. Sometimes we just send them one time to help make the diagnosis. Again, with Alzheimer's dementia, it can be very straightforward, and not every patient needs a neurologist. We have it. How many of you have had a really hard time getting in to see a neurologist or get your loved one in? we have a shortage and it's getting worse, not better. So it's very hard. So even if your doctor wants you to see a neurologist, it can be 6 to 9 months before you get in. But they do serve an important role, especially for patients with frontotemporal dementia. Go ahead, you have a question?
I do. Tell me the connection between the neurologist and Alzheimer's. I mean, I know I saw the outline and everything like this, but how does the neurology part manifest itself as in conjunction with Alzheimer's?
Well, I mean, it's a brain disease, and so neurologists are trained specifically, you know, they have the most training in disorders of the brain and spine. So
it would mean that they couldn't move? I mean, is it that simple? The person with Alzheimer's can't physically move, like they can't remember, they can't think? Is it that simple connection?
well, just the brain itself. Neurologists are trained in disorders of the brain and neurons, and so neurons affect the brain and spinal cord, so movement and brain. So, so it overlaps between what primary care physicians do everything, but not in as great detail. But so you don't have to have a neurologist if you have Alzheimer's, but certainly they do have a lot of extra training in it as well.
Right. Well, I'm just thinking of my husband and the connection between, you know, the beginnings and then what a neurologist, how it would manifest itself in a neurological way. Would he not be able to walk, or would he not be able to move?
Well, it ends.
You see what I'm asking?
Well, Parkinson's disease, I don't know if you're getting it. Parkinson's disease is a neuromuscular disorder, which can also, patients have dementia with, especially Lewy body dementia. So that would be a case where often patients do need a neurologist.
Okay, I see what you mean now.
And then there are some other conditions. There's some other more.
Yeah, so I think you're talking about disease progression. So in early stages, people can go see a neurologist for an evaluation because they're having problems with memory, language, all the symptoms that we talked about. And because that's being generated from the brain, the neurologist is often the first one who sees them. You may not see your neurologist because lots of times it is moderate to late stage before somebody gets a diagnosis. So there may be more advanced neurological symptoms at that point, but the neurologist has an understanding of how the brain works and how the symptoms might correlate with what part of the brain. That's why they're the specialists.
Right. So the symptoms would manifest themselves so that you would need to have a neurologist or consider that as you go into the different parts of.
Right, so the neurologist is going to be the specialist who will help make the diagnosis if a physician is not sure what's going on.
Right.
Trying to clarify a diagnosis, or if there are additional problems beyond. So frontotemporal dementia, for instance, often has a correlation with Lou Gehrig's disease. So you want a neurologist involved if there's any conflict that way.
I understand it now.
Yeah. So we often don't refer unless the patient really feels strongly they want to see a neurologist, or if we can't make the diagnosis. Or one of these more complex diseases. And then we often do refer to a neuropsychologist. Has anybody had their loved one see a neuropsychologist? Again, if there's more psychological issues, maybe there's a lot of depression involved, or if it's unclear if a patient has more mild cognitive impairment or early dementia, and they do usually a 4-hour or so battery of testing, kind of figuring out a lot of baseline cognitive reserve and testing. Psychiatry, we sometimes get psychiatry involved if there's a lot of depressions. You know, as it may have been addressed earlier, a lot of times people who are severely depressed masquerade as having dementia, but if we treat their depression, we find out that actually they may not have dementia, or it may not be as severe as we thought. So this whole, you know, different people will need different members of their team at different times, and these are different people that your loved one may need to be referred to at different times. Yes?
We went to a neuropsychologist.
Uh-huh.
And he diagnosed my husband with FTP.
Okay.
And he suggested maybe going to a neurologist. But what will a neurologist with the diagnosis? I mean, what is there any benefit going to a neurologist too?
In addition to your primary care physician?
Yeah.
Not necessarily. We can talk afterwards if you want. More maybe just a 1 or 2 time visit to corroborate the diagnosis. In that case, if imaging hasn't been done, that is when some PET imaging or MRI can help to really corroborate that diagnosis. There's not always any real definite treatment. So other team members can be speech therapy early, especially for mild cognitive impairment. Our speech therapists can often help with things like a lot of just tasks and using calendars and lots of exercises, more mental exercises. Physical therapy, occupational therapy can help. Yes, you have a question?
What is the percentage of Alzheimer's? Do men have more than women?
It's actually a little bit higher in women. I believe it's 2/3 women. Yeah. So the percentages are, I usually have this, and we probably do. By the at the age of 65, 1 in 9 of people age 65 and older will have a diagnosis of dementia, and by the age of 85 and older, it's 1 in 3. Is that correct? 1 in 3, 85 and older. And that's for Alzheimer's, I believe. Is that correct? Yeah, so it's a little bit higher if you add in the other forms of dementia. And then getting back, other reasons to see a neurologist. Of course, neurologists deal a little bit with stroke, and so with vascular dementia, sometimes we refer. Okay, so I'm going to give you just a little bit. Tell me, what are we supposed to stop at 11:30? Ideally. Okay, we're just going to go a few more minutes. I'll be fast. Okay, so getting the most from your appointments. Caveats here. I know seeing your primary care physician is probably frustrating because we don't have enough primary care physicians either. It's hard to even get one these days, and we're rushed for time, and we're always staring at our computers trying to fight these battles for you too. But some insider tips are: be organized. Have a brief list of observations or questions. Most of us are never upset if you come with that list, and we will read it, okay? We may not read it while you're there, but we will read it. Give examples. So if you remember during the course of the last, keep a little journal. And if something weird happens or behavioral, keep a list, and that will help us know what might be going on with your loved one, especially if you're trying to help us make a diagnosis of dementia. Try to keep that list of medications updated and bring it with you, especially if you're seeing lots of specialists and they're adding medications and supplements. Some doctors don't want to see it, but bring it anyway. Schedule appointments for your loved one's best time of day. I know you can't always get it, but do your best to bring them when they're at their best. And again, send a summary before the appointment if you can. Bring records from other appointments. Ask for clarification and write notes. Bring your little notebook and write everything down you can. Again, keep a logbook, especially when starting new medications. Record observations, good and bad. A big point here is be aware that illness can make memory worse and can cause changes in behavior and alertness. How many of you are familiar with delirium? What that is? So delirium is a really important topic. Again, could be another conference. So delirium is an acute alteration in alertness. It's this waxing and waning of attention. So it is actually a medical emergency. We don't often treat it as such or detect it, but so when somebody has dementia, it's a slow progression. So Alzheimer's dementia is a slow loss of memory over 10 years. When somebody is okay 1 in the morning and then they are acting completely beside themselves later in the day. They're picking at the air, they're doing weird things. That's delirium. They could have a urinary tract infection, they could have an electrolyte abnormality, they could have another type of infection, and they need to be seen, and you need to let your doctor know. It happens most commonly in the hospital. We don't treat it enough or address it enough in the hospital, but it can make the memory worse. And so it can make somebody who's just slowly progressing with dementia get worse, and then it happens a lot after surgery, but it's something to be aware of. If your loved one ever gets hospitalized and you notice it, let the nurses know. And again, we're working on doing a better job at treating that. Yes?
So sundowners, is it different?
Yes, it's actually part of the same spectrum. It just happens more, it's kind of the same thing, except that it happens more routinely in somebody with it. It's kind of, I guess somebody with dementia may sundown every day, and so it's probably not acute delirium, but it's a little bit of the same phenomenon, just not necessarily due to an infection. But just be aware of it. Okay, I'm going to turn it back to Helle for 5, maybe 3 minutes. Okay. Yeah.
So to answer the question, it's always a question, is it a trend? So we know in moderate stage in particular, you can develop behavioral changes in Alzheimer's disease or any of the dementias. So have we just kind of been seeing those increase over a period of time, 2 to 3 months, versus a very sudden change over hours or days? That's going to be delirium, sudden change. Okay. So the management of memory problems, most of it really doesn't come from medications. It comes from how you affect the day. And the important rules are going to be providing routine and structure. We all do better that way in terms of how we function, how we remember things. It's very important for the person with Alzheimer's disease. It's important that they have quiet times during the day, that they not run all day, or that we try and keep them too stimulated, because we're going to get overstimulated. So morning and afternoon, there should be a period of quiet, 30 to 40 minutes, where they're sitting and just tuning out the world. As time goes on, you want to modify the environment so it's less cluttered, less confusing, less challenging, and the same with tasks. You're going to make them simpler. Is it causing frustration for them to try and do it? Can you change that by stepping in and helping, or do you need to assume the task? And we know you're going to assume more and more of the tasks. The challenge becomes your communication changes. You give more concrete examples, simple instructions or directions. Do you need to include touch with your directions? And not talk in the abstract, not give too much information, because that will overload as they're having more problems processing information. So keep it short and sweet. Be about reassurance, about calmness. If you're feeling tense, anxious, angry, irritated yourself, and they see that on the face, because this is how they compensate when they don't understand language, is they're watching you for cues. So if you need to excuse yourself for a minute and just recompose, do that, because you'll head off a lot of behavioral issues. The main thing is to bring the familiar and the loved to them every day. So you're honoring body, mind, and spirit. What were they about? Think back 10, 15, 20 years. Think back when you were first married or when you were growing up with a parent. That's the long term, and that's what that person's been about all their lives. There are medications for memory. That's a discussion with your doctor. So in the first class, you use either Aricept, Exelon, or Racidine, depending on tolerance. Some people can't tolerate one, but can tolerate another. Some can't tolerate any of them. And then the second class of medications is Memantine or Namenda, indicated for moderate stage forward. Ideally, we use both drugs, so as one starts to kind of not be as effective, they still have effect all the way through the disease. But we know the disease is going to progress anyway. you add the second one, but not everybody can tolerate 2 drugs. So the other part of what after a diagnosis is to get smart and get help. It really does take a village. So speak up for yourself. Be ready to ask for help and to accept help when it comes your way. So I was thinking about this morning. As young parents, we partner in raising children. We have help, and yet when we become a caregiver, we often push away the help. And it's important to have those extra people come in, because that's one way you honor the spirit of the person. This person was loved by many people, so don't push those people away. Incorporate them in the daily routine. I often say have that honey-do list ready. So there are angels who walk on earth, right, who come and say, what can I do? Let me know if you need help. So have that honey-do list. I am sick to death of cooking. I don't like my own cooking. My wife's not eating very well. Make us a couple of dishes that we can share. I need to go get my hair cut on Saturday. If you could come and just visit with him. And please don't use the word sit with him, right? That's a negative connotation. And you don't want your loved one to feel like they're being babysat. Because what you're going to get is no. So somebody's coming by to visit, all right? Get educated. Know what resources are out there. Know about your person, what works for them, what doesn't work for them, because a big part of your role is advocacy. So working with the doctor, trying to get a diagnosis and saying, you know, doctor, I understand that as we get older, our memory isn't as good, but I also understand from my reading that this is not normal aging. And here are the other symptoms I'm saying. And sometimes you have to plant the word. I wonder if this isn't Alzheimer's disease. Sure. Doctors don't like to give horrible diagnoses. They really don't. And they don't like to talk hospice. So sometimes we have to put the word in there for them. The other critical part of your team is your family, your friends, your faith community, all of your resources, home care agencies, daycare programs, activity programs. So you have Memory Matters, you have 5 counties, you have all kinds of things going on in town. Access those. Read, attend these workshops. I will say there are fabulous books on Alzheimer's disease. And there are lots of good websites. Go to the good ones, the Alzheimer's Association, the Alzheimer's Foundation of America, ADEAR, those kinds of things. Because a lot of the others, there's a lot of anecdotal kinds of things, and it isn't always helpful. Plan ahead. So advanced care directives, financial and legal planning. What happens if something happens to me? What happens, where do we place if that situation comes up? And when you have help, when you've tapped into those resources, make use of the time. That's time to reclaim for yourself. And that might be, for you, it might be just taking a walk. It might be, as one man told me, I just want to go sit under a tree and read. I want to go sit at the spa. I want to take a nap. It's whatever works for you, okay? Because it's equally important that your body, mind, and spirit be acknowledged. And the last few points here, don't assume others know what you need. Sometimes we hide behind our pride, or they ought to know. And interestingly enough, I worked with a pastor who was guilty of this. Well, they should know that I need help. They don't know. People assume things are going on, but they don't know how to help, and that's where you want that honey-do list. Use an ongoing family conference to just review changes, review needs, come up with a schedule of who can provide transportation, who can come spend time with dad or mom. Don't isolate. Look at your own social network. So those times that you have help, it's important that you have that outside sense of you to talk. Sometimes it's venting. Sometimes it's just saying, oh, there's still a world out there. And it's okay to laugh. It's okay to have fun for myself. The big part of it is that you're leaving somebody with him or her to also have fun for themselves, okay? Proactive rather than reactive planning. Remember that the person is experiencing changes in the brain. They can't change what they're saying, how they're acting, how they're changing over time. We're the only ones who can. Oops. And I'm just going to leave it there so we close. This is from a caregiver's prayer, and I think they're fabulous words. May you always be open to receive that which will help, the wisdom of others, their kindness, and their support. May you be responsible for your own ongoing care, knowing that you cannot share what you do not have. May you always stay open to the possibilities as they evolve, growing closeness, widened perspective, deepened meaning. When you take the time to get help, to get educated, to learn to be in the moment, to accept what is and not keep trying to cling to what was, there are truly moments of joy and laughter to be found. And there's a meaning to be found in having given the greatest gift of self and being a caregiver. Thank you.